Good evening. Today we are going to discuss about demyelination beyond multiple sclerosis. Now, disease of myelin can be divided into two categories. One are the dysmyelinating disease, another is the demyelinating disease. And when we read about demyelinating disease, these are the following etiologies. One is the autoimmune causes, secondly infectious, third toxins, then vascular and hereditary disorders. Out of all these autoimmune causes, they form a major part. Now, when we think of autoimmune demyelination, the only entity which comes into our mind is multiple sclerosis. But with the new advancements, new entities have come into picture. These are NMOSD, MOG disease, MOGAD, and the last one is GFAP astrocytopathy. Now we know that myelin, it is concentrated in the optic nerves, brain and the spinal cord. So mostly the patients with demyelination, they present with the following features like optic neuritis or myelitis or cognitive dysfunction. So whenever a patient comes to you and you're thinking of demyelination, what are the things which can make you think that this is not MS? Like, what are the various red flags? These are by patient having bilateral optic neuritis or the patient who is having unilateral optic neuritis with poor visual recovery. Patient presenting with area postrema syndrome like intractable nausea, vomiting, hiccups. Patient with complete transverse myelopathy with bilateral sensory and motor involvement, encephalopathy and cognitive decline. So these are the four major entities. One is a multiple sclerosis, other is the NMOSD, then we have GFAP astrocytopathy, and then we have the MOG. When we learn the pathogenesis, we can see that in multiple sclerosis it is both the B cell and T cells which are playing an important part, whereas in NMOSD it is the antibody, that is IgG antibody, which is aquaporin P4 antibody, which is formed in the periphery. It enters into blood-brain barrier and then it causes complement mediated cytotoxicity. In the GFAP astrocytopathy, it basically causes GFAP papillitis. There are CD8 cells which play a major role and causes axonal swellings. In Moggay disease, it is a CD4 cells which play the major part. Now, what are the clinical features of NMOSD? One is the optic neuritis, which we know very commonly. Then we have transverse myelitis, area postrema syndrome, brainstem syndrome, diencephalic syndrome. Rarely, patient can have myeloradiculopathy as a presentation of NMOSD, cerebral syndrome, acute myopathy with hypercemia, and uveitis. Now, when a patient comes to you with optic neuritis, we have to see whether it is a typical optic neuritis or atypical optic neuritis. In typical optic neuritis, it is the younger age, that is 20s or 30s age group female who is white in ethnicity and who has a vision loss, which will start firstly and then it will increase in 1 to 2 weeks. After 2 weeks it will decrease. Whereas, what are the signs which can help you say that this is not typical optic neuritis? These are if the patient is having age more than 45 years, non-white ethnicity, male gender, patient having bilateral simultaneous optic neuritis which is painless, or sometimes pain is present which is persisting for weeks. There is recurrent stereotype bouts of pain, persistent positive visual phenomena. Patient who is having severe vision loss at presentation which is progressive and sometimes presenting as optic atrophy at the presentation, it also shows that this is not typical optic neuritis, this is atypical optic neuritis. Also, absent RAPD, severe optic disc edema, vitreous inflammation, optic disc hemorrhage, systemic symptoms can be seen as a part of atypical optic neuritis. Now, does history and examination helps us in differentiating these entities? Answer is yes. So first is the age. Now we know that in multiple sclerosis it affects mainly the patients within second decade, whereas in the aquaporin 4 it is in the fourth decade, and females are more commonly affected than males in MS and aquaporin, whereas there is no gender predilection in Moggay disease. Bilateral optic nerve involvement, it is seen in both aquaporin 4 and MOG disease. Severe vision loss at nadir, it is seen in both of these entities. Risk of recurrent optic neuritis, it is very frequent in aquaporin 4 and Moguer disease. Steroid dependency, it is seen in the Moguer disease. Risk of blindness, it is seen in the aquaporin 4 positive disease. And disc edema, it is very frequent in the MOG disease. Now, can imaging helps us in differentiating these entities? Answer is yes. Now, if these are the zoomed cut of the optic nerve along with the optic chiasma, we see that in NMOSD, it is a posterior part of the optic nerve which is most commonly affected. It is a longer segment of optic nerve will be involved along with the optic chiasmal involvement. Whereas in the MOG disease, it mainly affects the anterior part of the optic nerve. There will be disc edema, bilateral disc edema. In multiple sclerosis, there is a shorter segment of the optic nerve involvement. Now, can imaging help in differentiating the cause of myelitis? Answer is yes. There are some clues which can tell you that this is a case of MOG and this is a case of NMOSD. In the MOG group of pattern, the upper part of the brainstem is involved and the lower part of the spinal cord is involved. A patient who presented to you with myelitis, who had a very good recovery, but then had residual bladder, bowel or sexual dysfunction pointing towards a chordae involvement, it shows that it can be a case of Moguer disease. Whereas in the NMO, it is the lower part of the brainstem and upper part of the cervical spinal cord which is involved. Now, these are some pictures of the imaging of NMOSD. We can see that there is optic chiasmal involvement, lower part of the brainstem and the upper part of the spinal cord which is involved in NMO disease. Then in Moguer, we can see that it is the anterior part of the optic nerve which is involved. There is perineural involvement and along with it, you can see it is a cauda conus involvement. Now, is there any diagnostic criteria for NMOSD and what are the core features? We have the 6 core features. One is optic neuritis, acute transverse myelitis, area postrema syndrome, acute brainstem syndrome, symptomatic narcolepsy or acute diencephalic syndrome, symptomatic cerebral syndrome with NMOSD typical lesions. Now, if a patient is aquaporin 4 positive, then only one core feature is required. Whereas if a patient is having, we are suspecting that this is a case of NMOSD, but the antibody comes out to be negative, then in that case at least 2 core clinical features should be present, out of which one core should be optic neuritis, acute transverse myelitis or area postrema syndrome. Dissemination in space should be there and fulfillment of MRI requirements with the exclusion of other diagnoses. Another important feature which I want to highlight is that in MOG disease, it is the ADAM, that is acute disseminated encephalomyelitis like lesions are present. If we see that this flare images are showing large fluffy cortical and subcortical hyperintensities in a patient with MOG disease. Now in CSF, the pleocytosis will be seen in the MOG and the NMO more as compared to that of multiple sclerosis. OCBs are positive in MS and in serological biomarkers we have anti-MOG antibody positive in MOGAD and anti-aquaporin 4 seen in NMOSD. Coming to the treatment, till now we know that we are using rituximab, which is mainly anti-CD20 and anti-CD20 monoclonal antibody. It mainly causes depletion of the B cells. But when we read about the pathogenesis of NMSD, it is that plasmablasts also play a very important role. So some patients, even who are on rituximab, they will have relapses. The causes can be many, that because of the plasmablasts which lack anti-CD20, so these cells will cause relapses. Another factors which play a very important role in the pathogenesis are the eosinophils, neutrophils, complement. So the many drug therapies, they are targeting these entities also. Now coming to the treatment of MOGA disease, we know that if a patient is, and we are suspecting the MOG disease, if the test is positive for the MOG antibody, then we have to give treatment for 6 months. After 6 months, we have to repeat the MOG antibody. If it is still positive and if the first relapse was very severe, or um, there was other relapses were present, then we have to continue the corticosteroid and immunosuppression. And if it MOG antibody is still positive at after 1 year, then we will have to give the long term immunosuppression. Now, few words about GFAP cytopathy. It is also a autoimmune disease which is steroid responsive and relapsing. Patient mainly present with meningoencephalitis, meningoencephalomyelitis, myelitis, optic dysedema, tremors, and ataxia. In the CSF, GFAP IgG will be detected, and 1 in 4 patients they have coexisting neoplasms like ovarian teratoma. Thank you.